Uh, so is it visible?
Yes.
Okay. I would like to thank the Indian Foot and Ankle Society, the President, Dr. Mahendra, Honorary Secretary, Dr. Kumar Shantanu, and most importantly, the academic coordinator, Dr. Maninder Shah, for this great opportunity that they have given me to present X-rays in foot and ankle to the members of the Indian Foot and Ankle Society. So before I begin, I would like to say at the outset that radiological examination of the foot and ankle is not a substitute for clinical examination at all. The clinical examination should always precede radiological examination. And again, I should reiterate that it is not a substitute for clinical examination. One should have a thorough clinical examination before going on to doing a radiological analysis of the foot and ankle. So the type of radiographs for the foot that are normally taken are routine radiographs. There are specialized radiographs, there are weight-bearing radiographs, and then there are stress radiographs. So that is how my presentation would be divided in these four categories. So beginning with the routine radiographs are non-weight-bearing radiographs, which are indicated in suspected fractures, as well as for post-operative evaluations. And routine radiographs of the ankle include the AP, lateral, and the mortise view. And for the foot, they include the AP, the dorsoplantar view, the lateral view, and the oblique view, which is taken in both internal as well as external rotation. So this is an example of an AP view of the ankle with the patient supine and the beam centered over the ankle joint, and the patient lying supine, and the X-ray tube is 0 degrees to the vertical. For the mortise view, the foot is rotated internally at an angle of 15 degrees, and the X-ray centered again at the ankle joint. Similarly, for the lateral view, the patient is placed in the lateral decubitus position with the affected foot down, resting on the cassette, and the X-ray beam is again centered on the ankle joint. So these are the AP, lateral, and the mortise views of the ankle joint in successive order as seen on this slide. So when assessing a lateral view in a trauma situation, one should look for the posterior malleus, the direction of the fibula where it goes, and the outline of the fibula should be always seen. The dome of the talus should be centered over the tibial plafond, and it should be congruous with the tibial plafond. An important injury that is commonly missed are avulsion fractures of the talus by the anterior capsule, which should be looked for and assessed in soft tissue injuries of the ankle. So this is an example of an ankle fracture with a posterior malleus fracture and a displaced fibula fracture with the talus dome not being centered on the tibial plafond. On looking for coming to the non-weight bearing X-rays of the foot, we have the AP X-ray of the foot, which is taken with the beam centered on the second tarsometatarsal joint. And this is an example of an AP as well as a lateral view of the foot, which is non-weight bearing. The non-weight bearing lateral view is taken with the X-ray beam centered over the calcaneocuboid joint. This is an oblique X-ray of the foot taken in an internal rotation view. Now, internal rotation X-ray helps in evaluating the anterior process of calcaneum and the cuboid with the fifth metatarsal. Similarly, an external rotation oblique view is done to see the medial column of the foot, the first metatarsal, the navicular, and the talus. Coming to weight-bearing radiographs, which are the most important part of radiological examination for any foot and ankle surgeon, because they tell the functional relationship of all structures under physiological loads. So the weight-bearing radiographs of the ankle are indicated in flat foot, as well as to assess the integrity of the deltoid ligament. Similarly, weight-bearing radiographs of the foot are indicated to assess subtle injuries of the midfoot, to assess the stages of flat foot, to assess the deformation that takes place in neuropathic foot, as well as to assess various angles that are used for treating and evaluating the hallux valgus of the foot. Now, this is an example of a weight-bearing, what weight-bearing can do to a normal-looking X-ray, and an aqueous X-ray of the foot on weight-bearing shows a very ghastly injury, which is a pure ligamentous Lisfranc injury of the foot. So this slide basically shows that weight-bearing X-rays of the foot are rather important, and they should form an important part of radiological examination for any foot and ankle pathology. So for the radiological examination, which is done in weight-bearing, these are the devices that I use. I use a slotted box to slide in a X-ray cassette to do the AP X-ray of the foot. Then I use a stand, which is normally done for taking standing radiographs of the knee, assessing the foot and ankle as well. And I also use a step. The step is used to assess the lateral X-ray of the foot. So these are the devices that I use. These are the three devices, and they can help you in getting the weight-bearing radiographs of the foot as well as of the ankle. So this is an example of how the radiograph of the foot is taken with a slotted box. to see what effect the weight bearing has on the foot. And when looking for weight bearing axis of the foot, one should assess few radiological parameters, which include the talus-first metatarsal line, which should be parallel. Hallux valgus angles have to be calculated, which I'll be coming to in the next slide. The talonavicular uncoverage can be seen by assessing the axis of the talus as well as the navicular to differentiate between stages 2B and 2A of an adult acquired flat foot, as well as planning treatment for adult acquired flat foot as well. So coming to weight bearing axis of the foot, the hallux valgus angle is normally less than 15 degrees, which is formed by the axis of the first metatarsal and the proximal phalanx of the great toe. And similarly, the distal metatarsal articular angle is the angle between the articular surface of the first metatarsal and the shaft of the first metatarsal, and it should be again less than 15 degrees. The intermetatarsal angle is the angle between the first two metatarsals, and it should be again less than 10 degrees to be normal. The metatarsal break angle and talocalcaneal angles are again more theoretical than practical, which are used to assess the alignment of the foot on weight bearing. When assessing a lateral weight bearing axis of the foot should be placed again in front of either in front of a stand or in front of a step to see, and the X-ray should be focused on the calcaneocuboid joint with the tube horizontal. The weight-bearing X-ray of the foot, when taken laterally, one should look for the superior border of the second metatarsal, which should be continuous with the superior border of the medial cuneiform. And on weight-bearing, if there is any plantar or dorsal displacement, it indicates an instability, which can be a subtle marker for a Lisfranc injury. Similarly, when assessing the lateral weight-bearing X-ray, one should look for a few angles, like the lateral talocalcaneal angle, which is normally 25 to 30 degrees. The fifth metatarsal base height from the floor, again less than 3.8 centimeters. And the calcaneal pitch angle, which is formed by drawing the lowermost border of the calcaneum and the horizontal, which should lie between 10 and 30 degrees, which is used to assess both flat foot as well as cavus feet. And the Bowler's angle once standing, which tells how much there is heel depression up following a calcaneal fracture malunion. Weight-bearing X of the foot. This is an example of a weight-bearing X of the foot of the lateral view, showing a hindfoot varus. So there is a increased calcaneal pitch angle, which shows a cavus, and the fibula becomes posterior. The talus has a double dome, and there is a see-through sign that is seen between the talus and the calcaneum, which is basically showing the sinus tarsi, indicating that the hindfoot is in varus as well as there is a cavus. So these radiological markers of hallux valgus have been defined by the great Michael Coughlin in his paper in 2002, which was adopted by the AOFAS as its standard for surgery of the forefoot. So coming to the ankle weight-bearing X-rays, the AP, the mortise, and the lateral view are again taken with the patient bearing weight using the devices that I've mentioned before. And there are oblique X-rays as well taken for the ankle, which are taken both in internal as well as external position. The internal rotation X-ray is used to assess the distal fibula and the subfibular space, while the external rotation X-ray helps in assessing the posteromedial part of the talus. Similarly, coming to the stress radiographs help in evaluating the integrity of the capsular ligamentous structures, which can be damaged in trauma as well as disorders of the ankle and midfoot. And if the condition is painful, one can even inject a local anesthetic into the structure that is damaged to adequately assess those structures on doing a stress radiograph. So this is an example of an anterior draw stress radiograph, stabilizing the tibia and pushing or pulling the heel to see for displacement of the ankles, suggesting instability of the anterior talofibular ligament, and instability of more than 2 mm compared to the opposite side is an indicator that the ATFL is gone. Similarly, a gravity stress view is an important X-ray to assess isolated fibula fractures, differentiating between the supination external rotation type 2 from the type 4. This X-ray is done with the patient lying lateral and the affected side lying upwards. And as gravity takes its effect, the fibula fracture displaces and the middle joint line opens up in cases of a supination external rotation type 4 injuries, which need to be fixed, unlike a type 2 injury, which may or may not require surgery. A talar tilt X-ray is done by holding the heel and stabilizing the tibia and giving a varus stress. And this helps in assessing the lateral ligament integrity, particularly the calcaneofibular ligament, and a displacement of over 10 degrees indicates an instability of the calcaneofibular ligament. Similarly, internal and external stress rotations can be given. An external rotation stress view is used to look for integrity of the syndesmosis. If an syndesmotic injury is suspected, an external rotation stress helps in evaluating that by looking at the tibiofibular clear space as well as the tibiofibular overlap on the AP X-ray. Stress radiographs can be done in cases of impingement when dorsiflexion and plantar flexion are carried out to look for lesions that are impinging, that have been clearly described in our article that is written with Dr. Maninder and Dr. Injadit sir. And a stress radiograph of the foot, putting the foot in adduction, helps in evaluating for instability at the calcaneocuboid joint, and increase of more than 10 degrees uh, of uh, of uh, of the angle indicates an instability of the calcaneocuboid joint. Similarly, abduction and adduction stress cues can be done to assess for integrity of the Lisfranc ligament and to look for subtle changes if there is a Lisfranc injury. Similarly, there are certain specialized radiographs of the foot and ankle. The Kerry canal view is done for assessing the talus neck, which is done with the foot positioned in plantar flexion and pronated 15 degrees. And this helps in assessing the entire talar neck, and it is a very important tool to assess intraoperatively when one is using the C-arm to see how the talar neck looks like, how the reduction is, and how much the fracture is displaced. A midfoot projection X-ray is again done with the beam projected perpendicular to the midfoot. Broaden's view is something that is a bit archaic, and in the era of CT scan, I would say that it is something more theoretical than practical. It is done with the foot in 45 degrees internal rotation, and the beam centered on the fibula at angles of 10, 20, 30, and 40 degrees from the vertical towards the cephalad side. And this is again an example to show how much the subtalar joint is fused following subtalar fusion to see parts of the subtalar joint both from the anterior side to the posterior side using the Broaden's view. This is helpful in assessing calcaneal fractures, but CT has largely replaced Broaden's view as a preoperative study for evaluating calcaneal fractures as being more easy to carry out and more convenient for the patient as well as for the surgeon. Radiographs for calcaneum are done for assessing calcaneal fractures, to assess bony corrections, to diagnose Haglund's exostosis, as well as to look for tractional spurs. So two plane radiographs are carried out, the first being the Harris axial view, which is done with the X-ray beam projected at an angle of 25 degrees from the vertical, and the foot being positioned with a device in dorsiflexion. So the X-ray here is projected, the beam is projected on the ankle joint and the Achilles tendon insertion, and this shows the alignment of the heel. It shows the subtalar joint and to some extent the calcaneocuboid joint as well. The lateral view of the calcaneus is carried out again as is done for the lateral X-ray of the foot. There are two common radiological parameters that are used to assess calcaneal morphology on the lateral view, which are the Bowler and the Gissane's angle. The Bowler angle is drawn between the anterior and posterior surface of the calcaneum, the superior part, and it helps give an idea about the calcaneal heel height. The normal Bowler's angle is between 20 and 40 degrees and can be disrupted both intra as well as extra-articular fractures of the calcaneus. The Gissane's angle is an angle formed in the articular posterior facet of the calcaneus below the lateral process of the talus, and an angle of over 130 degrees suggests depression of the posterior subtalar articular facet, and it has to be restored to assess for intra-articular reduction of following a calcaneal fracture fixation. Again, coming to Bowler's angle, this slide is slightly misguided. I would not say that it has limited usefulness. Bowler's angle is very important to look for heel height, and there have been several studies to suggest that heel height and heel width are important parameters to assess for integrity, to assess calcaneal fractures in terms of outcomes. The neutral triangle gives an idea of the bone quality of the calcaneum. On assessing the lateral view of the calcaneum, one should look for parallel pitch lines of Pavlov, and any part of the calcaneum that is above these Pavlov pitch lines is a Haglund deformity. And when doing an removal of this exostosis of the calcaneum, one should see that any part of bone that is left above the Pavlov parallel line should be removed. Calcaneum oblique views are done to assess for traction spurs. They are done in both internal and external rotation. The Saltzman view is an important specialized radiograph that is done to assess the alignment of the heel. It is done with the foot positioned on the X-ray cassette and the X-ray beam directed at an angle of 45 degrees from the horizontal towards the ankle with the patient standing. So this gives an idea of the alignment of the hindfoot. The axial alignment can be seen, and it is important to assess correction of the hindfoot deformity after correction, as well as to plan hindfoot deformities. I do it for all my flat foot cases when I'm planning a displacement calcaneal osteotomy, and I do it both before and after my osteotomy to look for how much the heel valgus has been corrected. The toe radiographs are done for injuries and pathologies of the toe. They can be oblique, AP, and lateral X-rays that are done to assess for subtle fractures of the toes. Sesamoid radiographs are carried out in this fashion with the toes dorsiflex and the X-rays centered on the metatarsophalangeal joint with the X-ray tube vertical. And the sesamoid radiographs help in assessing the subsesamoid joint space, which can be involved in degenerative changes. And if a person is having complaints following a hallux valgus surgery, one can always look for positioning of the sesamoids in the sulci, whether they are there or not, as well as to look for sesamoid osteonecrosis. Assessing the radiological parameters of the ankle, I would like to say that most parameters can be assessed on AP view. There are only three that require a mortise view, which is the medial clear space, the talocrural angle, and the ankle instability sign. The remaining tibiofibular overlap, the tibiofibular clear space, talar tilt, talar shift, Shenton's line, and dime sign are all assessed on the AP view. This is a talofibular overlap, which is seen a centimeter above the ankle plafond, and it is between the middle border of the fibula and the lateral border of the tibia, and it should be more than 10 mm to indicate syndesmotic integrity. Similarly, the tibiofibular clear space is between the incisoral border of the distal tibia and the middle border of the fibula, and anything that is more than 5 millimeters indicates maladduction of the fibula or a syndesmotic break. The talar tilt angle is an angle between the ankle mortise and the superior dome of the talus, and a tilt of more than 2 degrees angulation indicates a disruption of the ankle, as is seen in this maladduced ankle. Similarly, a talar shift test is again not very significant, but it indicates a talar malposition or shift. The Shenton line of the ankle is drawn by connecting the articular surface of the medial lateral malleus as well as the tibial plafond, and it should always be compared to the opposite side. And similarly, again, a very important sign that is commonly seen on the AP view is the dime sign or the ball sign, which is formed between the lateral process of the talus, the lateral talus process, and the lateral and the distal part of the articular part of the lateral malleus. And it should form a sort of a coin or a dime. And any fibular shortening or fibular malunion results in disruption of this dime sign, and it is an important marker intraoperatively when checking the C-arm in fixing ankle fracture. The middle clear space is, as I mentioned, done on the mortise view, and it should be less than 4 millimeters. An increase indicates a deltoid ligament insufficiency or a syndesmotic injury that has also disrupted the medial structures. The talocrural angle is again done on the mortise view. It is an angle between the articular surface of the tibia and the tip of the medial and lateral malleus. 83 degrees is its normal value. Again, a disruption indicates shortening of the fibula, as in seen in this case. Ankle instability is seen by comparing the superior articular, the ankle joint space and the middle joint space. The both should be equal, and if the spaces are not equal, this indicates that the ankle is disrupted, as is seen in this malreduced ankle. The Lisfranc injury can be assessed by few radiological parameters, and there are few that are assessed on the AP view, like the lateral border of the first metatarsal in congruence with the lateral border of the medial cuneiform, the middle border of the second metatarsal, which has to be congruent with the middle border of second cuneiform, and the medial and lateral borders of the third metatarsal have to be congruent with the medial and lateral border of the lateral cuneiform, respectively, in the AP view. So these are the parameters that are seen on the AP view. On the oblique view, one should look for the fourth metatarsal being congruous with the cuboid, and this is done on the oblique view, as I mentioned. And similarly, on the oblique view, the fifth metatarsal should not be more than 5 millimeters beyond the lateral border of the cuboid. If there is disruption, it indicates it is a subtle marker for Lisfranc injury. Similarly, an important radiological marker for Lisfranc injury is the flex sign that is seen between the bases of the first and second metatarsal, which is basically an avulsion of the Lisfranc ligament. One should also look for the intra-articular spaces between the first and second metatarsal, which should be equal to the space between the middle and middle cuneiform. And any disruption indicates a Lisfranc injury. For assessing the flat foot, one should look for the Meyer's line. The Meyer's line is formed between the first metatarsal and the talus. Normally, this line is parallel, and if there is a disruption, they're distorted. On weight bearing, it indicates that the Meyer's line is distorted, and it indicates an acquired flat foot deformity. Again, a talonavicular uncoverage, as I previously mentioned, has to be seen between the axis of the navicular and the axis of the talus. If the angle is more than 7 degrees, it indicates a disruption. Again, as I mentioned, it indicates a forefoot abduction that is seen in stage 2B of the adult acquired flat foot. And if it is involved, it requires additional correction by a lateral lateral column lengthening. So, as I end, I would like to say that radiology has its limitations in terms of intra-observer variations, the magnification variations, and patient-to-patient variations. And due to these limitations, there are further techniques to help in investigating the foot and ankle conditions, like the ultrasound, the CT scan, and MRI, which my colleagues will be talking to you about in a short while. Thank you. And I would like to thank the Indian Foot and Ankle Society, and I would like to acknowledge PubMed, Dr. Rajiv Shah's book, and Mann's textbook for my material source. Thank you.
Great. Thank you, Ankit. I think that was a really exhaustive treatise on what all we can see on the X-rays, and I think you covered so much in such a short time. I'm sure you need a glass of water now after speaking non-stop for 20 minutes now. So thank you, Dr. Nikesh. Any comments on that?
Yeah, Ankit, can I ask a few questions? They are also sent by a few delegates, so we need to give them proper answers. The first question is, how do you take the weight-bearing X-ray in acute painful condition like ankle ligament injury or Lisfranc injury?
Sir, again, that is again a tricky situation. In a painful condition, taking X-rays weight-bearing is a bit difficult. But then again, they have to be taken. I try to give a local anesthetic at times when the patient is in too much pain. But if I am suspecting a Lisfranc injury, if there is a plantar ecchymosis or something to suggest, I do tend to put the patient in weight bearing as much as tolerated and take the X-ray. I would like the other delegates to also add on if they have some more suggestions.
Yeah, Maninder, can you add something?
What I normally do, so weight bearing is mainly required for ligamentous Lisfranc. So fractures we can see on the X-ray, or we can do a CT scan, but weight bearing is mainly required to see whether there is any ligamentous instability in the Lisfranc injury. So I think if you have significant suspicion of a ligamentous Lisfranc, then an MRI would be helpful. And if as soon as the patient is able to weight bear, I think a weight bearing view also enhances your recommendation for stabilizing that unstable injury. So I think definitely both of these have to be kept in mind. If you can't wait and you want to find out as soon as possible, I think MRI, or if you can wait, if there's no strong suspicion, then maybe you can wait for a week, let the patient weight bear, call him back, and then do weight bearing views. I think that's what I do. Yeah. But any comments from Dr. Nafisa, Dr. Daftari, Dr. Raghav, anything on the?
No, I don't have. I mean, I think you covered everything that could possibly.
But it's a good idea if we don't have the facility for an MR or an ultrasound. At least we have an option.
Yes.
Yes. We should not deny that patient. If in that situation it is done, plus an X-ray is always easier to interpret for the orthopedic or anybody seeing it.
The only thing I'll say is that you should absolutely, you have no excuse in today's day and age for not doing an X-ray. Just because you got an MRI, just because of CT, you should never have a situation where you don't. I mean, the number of times you end up with egg on your face because you did not do the X-ray is just unbelievable. So for a simple examination standpoint, and you must always get the first injury X-ray. And I would say that is the number one most important thing. And I think the second thing is that whenever you're interpreting any additional study, always look at the X-rays. And whenever you're looking at an X-ray, please make sure you look at the previous X-rays to see if something is new, something has changed, something has happened. I think for X-rays, that is probably the most important thing.
Yeah. Ankit, there is another question.
Yes, sir, please.
How can you assess the sesamoid positions in AP view in case of hallux valgus, and what would be the interpretation?
So in the AP view, I would like to get an X-ray of the opposite side to look for turf 2 injuries. I would like to see how much the sesamoids have shifted back from the metatarsalophalangeal joint. Again, an X-ray of one side in itself again is of no value at all. If the X-ray is done of both the feet and comparison is carried out between both the sides and the distance between the metatarsalophalangeal joint and the sesamoids is taken, it gives a good indication of if the patient has sustained a turf 2 injury with the disruption of the sesamoid ligaments that has led to proximal migration of the sesamoids.
And how do you take Broden's view in theater with C-arm?
Sir, with the CM, in the theater, I would like to keep the first. I would like to keep the X-ray beam vertical. Put the foot in 45-degree internal rotation. Center the beam on this tip of the fibula, and do an X-ray, and then do subsequent X-rays with the X-ray beam being shifted at angles of 10, 20, 30, and 40 degrees cephaloid each time, and looking for the subtalar joint from anterior to posterior.
Perfect.
Yeah.
And how do you assess the syndesmotic injuries with the X-ray? I mean, what are the X-ray features of syndesmotic injury like tibiofibular overlap or something?
Sir, I think
And how do you assess intraoperatively with the CM while fixing the injury?
Right, sir. I think I discussed it at length. Apart from the radiological parameters, I think it is very important to stress the syndesmosis. One can do a Rose's external rotation when one pushes the foot externally and looks at the syndesmosis, whether it is opening up. That is an important stress view that can be done intraoperatively. The Cotton's test has been described when one holds the fibula with a towel clip and tries to draw it externally, which is lost its value because lateral displacement is not as important as an external rotation, which gives a better picture of a functional syndesmotic injury. Apart from that, I think I've discussed at length the tibiofibular clear space, the tibiofibular overlap in my talk.
Yeah, and there is also a question from Dr. Atesh Garg. Can you please explain how to calculate the talonavicular uncoverage on radiograph? And there is also another question from Dr. Dayanidhi about the examination under GA for stress X-rays. I think that Ankit, you can answer those.
Right, sir. Sir, when assessing the talonavicular uncoverage, I draw the long axis of the talus and the long axis of the articular points of the navicular, and check the angle between the two. Anything that is more than 7 degrees indicates uncoverage of the talus head. And percentage calculation is sort of, it is not clearly mentioned anywhere, but part of the talar head that is uncovered as compared to the remaining talar head that is covered by the navicular is an important indicator. Any uncoverage of over 30% indicates that there is a significant forefoot abduction, and this needs a lateral column lengthening in maybe a Evans osteotomy or something or a Hintermann's procedure to lengthen the lateral column. So 30% is my cutoff, but on seeing the recent literature, I saw this value of 7 degrees, but I don't think there is any coordination between the 7 degrees and the 30% value. But the textbooks clearly mention that anything that is over 30% has to be treated with a lateral column lengthening.
Yeah, and Maninder, what are your views regarding the examination under GA? Do you go for it?
So I think
we never go for at least examination under general anesthesia for diagnosis.
I think with the advent of new techniques with the MRI and CT, I think majority of the diagnosis MRI, if you want to see instability, now we can see all the ligaments now on ultrasound, MRI, and we can make a decision pre-operatively whether we want to, and we can confirm that intraop. So I think we go in to the OT with the decision made to already operate, and then we can confirm it while pre-operatively. But I think just to do examination under GA to find out instability is quite rare. I think you go in with the mindset of just if you find instability that you will operate then and there. So and you will always want to do an MRI or ultrasound CT pre-operatively. So I think we should move on now. So next, I think we had a great discussion on X-rays.